Hello, my name is Chris Dellinger, and I will be doing the presentation today on behalf of myself, Sharon Tilka, and Christine Daniels, and we are representing WVU Medicine, Camden Clark Medical Center, in Parkersburg, West Virginia. The name of our quality improvement initiative is titled Nurse Floating and Competency Level. The approach that we utilized for this improvement initiative was the DMAIC process. And the DMAIC process is defined as a data-driven problem-solving technique that is designed to identify and address inefficiencies in a process. And what we were identified during our issues was our RN turnover had increased along with employee satisfaction, and employee morale was decreasing. And part of what we were finding as we were defining this was that the overall RN competency level was resulting in frustration for the staff, as well as in resulting into patient safety concerns. What was noted was that there was an increased number of RNs being pulled to work in a different area than they were originally assigned. And what we were finding is that their competency level was not competent to be able to take care of those patients. For example, if I was a med-surg nurse being pulled to a step-down unit or into the intensive care unit. So we had on a baseline average of 7 RN pulls per day, and our goal that we defined was to decrease this by 50%. So some of our background work included looking at the current staffing process to include our staffing office, to include the house supervisors and charge nurses to identify where the concerns was being originated. And we also had to define what a pool was, what a double pool, and what a multiple pool, and what did that really consist of. Once this was all defined, we went into the measure phase, and each inpatient nursing unit provided data on the number of pulls that they had from their respected areas for 3 weeks to help obtain our baseline. This is still currently being evaluated and collected every 2 weeks, and we do that during our payroll weeks to have the ongoing information to share with leadership and with our staffing office. Data collected also included the number of times the day shift charge nurse was pulled into staffing for baseline. And again, this is also part of the ongoing collection of data. And then another area we looked at was the RN turnover by med-surg and by the critical care areas. Part of our improve and analyze phase was to define the levels of care that is now standard work within our organization. And we standardize what level of care can be pulled to another area without cross-training. And then we standardize the experience required prior to pull and required for post-orientation period. So if we have a newly hired RN that has experience, they cannot be pulled from their home unit for 30 days. If we have new graduate RNs, they cannot be pulled from their home unit for 60 days. We also created and implemented cross-training competency checklists. We did this for our step-down area known as our ACU. They will have 1 to 2 shifts to cross-train. And we also had critical care cross-training, and they would have 1 to 3 shifts based on their experience. Then we implement and we would track this RN competency in our Chronos system. That way we have documentation for everybody to be able to see that. We did standardize the order of pulls, so our travelers are pulled first, then our PRN staff, and then our full and part-time staff. We did create a pull survey to evaluate the experience of the RN being pulled. Again, that is anonymous, and it does get routed to the manager for real-time follow-up so we can address any issues or concerns. We restructured our bed huddle calls to include staffing discussion. This now occurs 2 times a day. This is 5 days a week. Our ancillary departments also joined this call to help facilitate the flow, and physician involvement is now in part of our bed huddle process. We did gain senior leadership support, and they continue to support the project today. Our improve is several standards of work that was created, which I mentioned was the levels of care, the RM pull order, our resource manuals for the nurse that's being pulled to the unit to utilize, and that way it gives them any information about the unit that they may not have had. The competency levels are defined. as well as entered into the chronos. And then the house supervisors now have a rounding checklist, as well as they have dedicated rounds every shift to make sure that they're touching point with the charge nurses on every unit at least twice per shift. We have made substantial progress, as our poster depicts, and you can see our baseline data to where we are today, and we have seen a downward trend of our pulls. We are not into the sustain or the control phase as we're still working through that piece of our project. Thank you.